Hello everyone, I'm Dr. Randall Gates, board-certified chiropractic neurologist and chiropractic physician. Today I'm talking about fibromyalgia, a topic I've done many videos on through the years, but I think it's time to bring you with an up-to-date version of the most recent scientific literature and to kind of do a synopsis to further verify that fibromyalgia patients are not making up their symptoms, that we know so much more about the condition currently, and hopefully you'll glean a lot of good information from this topic in this discussion. Go ahead and read the disclaimer on the screen, pause the video. None of this is intended as medical advice, only thoughts for you to talk to you and your doctor about. Fibromyalgia is a very interesting condition. It's a condition that some textbooks refer to as drawing more anger from doctors than any other condition out there. There are many reasons for that, largely because fibromyalgia patients look healthy. They look relatively normal. And when doctors deal lots of times with fractures and heart attacks and brain bleeds, seeing a patient who has exquisite pain throughout their entire body may be initially confusing and reason for drawing anger from some of them in the past. This is documented in textbooks, so I'm not just making this up. Nonetheless, fibromyalgia patients do suffer with chronic widespread pain and oftentimes have severe associated symptoms of brain fog, cognitive dysfunction, fatigue, and lots of times there are many other associated symptoms such as headaches and TMJ disorder that I'm going to go through. So that is kind of our intro, and basically that is exactly what fibromyalgia is. It is a condition of widespread pain, but we cannot discount the brain fog and the fatigue. And lots of times the brain fog and fatigue are more prominent symptoms even than the pain. The pain is not just in one body part. The pain is not just in the spine. The pain typically is involving several quadrants of the body. So the arms, the legs, spine may be involved. But we don't necessarily just want to lump in TMJ, temporomandibular joint dysfunction, or headaches into that pain. Those are kind of considered separate entities in how we classify fibromyalgia at this point in time. In terms of who is affected with fibromyalgia, largely there's a female preponderance. These are women typically in the prime of their life, very similar to postural orthostatic tachycardia syndrome that I talked about last month. And it's a really common condition. It's accounting for upwards of 5% of the female population has fibromyalgia. So it's not an uncommon condition. Some estimates are around 1 to 2% I've read. But needless to say, it is something that's very, very important that everybody knows about and understands, particularly for those loved ones in your life. Because again, even to them, lots of times fibromyalgia patients appear healthy and without significant disability, even though they feel disabled and lots of times are disabled. Because of the severity of this condition, also going back, lots of times there can be significant economic and societal burden on fibromyalgia patients because they may not be able to go to school during their formative years. They may not be able to engage in a career path that they really want to because it may be affecting it being the condition affecting their symptoms. Again, fibromyalgia is commonly misdiagnosed. It can be classified as other problems. Frequently, fibromyalgia patients may take a long time to receive the appropriate diagnosis when the pain presents and the cognitive dysfunction and the fatigue. Frequently, patients are referred from their general practitioners to rheumatologists and or neurologists. Lots of times there are many, not only are there long wait times, but there are many tests that have to be conducted to ultimately rule out other conditions. It's important to note there that fibromyalgia is not a diagnosis of exclusion, meaning you don't have rheumatoid arthritis, so you have fibromyalgia. That's actually not how it works. You don't have lupus or multiple sclerosis, so that means you have fibromyalgia. That's not it. Fibromyalgia has its own diagnostic classification, and as you'll see in this video, there are underlying conditions that cause this presentation of fibromyalgia. I think many of you know that there are conventional therapies out there, medication-based approaches that throughout the literature are discussed by pain management specialists, rheumatologists, that are not felt to be producing the outcomes that we all hope that they would. Fibromyalgia symptoms, there's a myriad of them. You can read them here, but particularly widespread pain, muscle joint and stiffness, lots of times associations with irritable bowel syndrome, fatigue, mood disorders, cognitive dysfunction, anxiety, depression, hypersensitivity to touch. How often I've heard fibromyalgia patients say, I can't give somebody a hug, or the shirt hurts my skin so much, I don't like to wear a tight shirt, or other clothing may be really unpleasant. So those are common symptoms of fibromyalgia. Now, going back to 1990, we had the 1990 American College of Rheumatology's guidelines for diagnosing fibromyalgia. At that time, it was pretty rudimentary. It involved the aldometry test, which is where a doctor would push into 18 designated spots throughout the body. And if a person was hypersensitive to that amount of pressure, called allodynia, then they would be considered as having fibromyalgia at 11 out of the 18 points. We've since moved away from that criteria. Some doctors still use it in clinical practice, but now the 2010, then 2011, if I remember correctly, and now 2016 American College of Rheumatology's guidelines more is, let me say it this way, is a composite score of not only where your pain is, all the areas of the pain, gives the doctor certain point systems to go through. Do you have fatigue? How severe is it? How severe is your brain fog? To then create this symptom score of, do you fulfill fibromyalgia or do you not? Mimics of fibromyalgia do include celiac disease, hypothyroidism, Lyme disease. I'm going to talk about that later. Rheumatoid arthritis, chronic fatigue syndrome, myofascial pain, lupus, multiple sclerosis, and we could even throw in postural orthostatic tachycardia syndrome, which can overlap with fibromyalgia patients as well. I think it's important here to go into the causes of fibromyalgia. Those causes do include trauma, autoimmune disorders, neuropathy, specifically small fiber peripheral neuropathy, mast cell activation syndrome, and the question mark of Lyme disease. These are the root causes of the condition, and hopefully by the end of this video, you'll really understand how these core causes affect someone's pain, fatigue, and brain fog on a daily basis. I think we pretty well went through the comorbidities, but here you can read them again. Comorbidities of fibromyalgia do include irritable bowel syndrome. So you would know that as pain and cramping, bloating, distension after eating meals, abnormal stool habits. So it may involve diarrhea, constipation, a mix of both, one or the other. Relief of symptoms after having a bowel movement is a common symptom of irritable bowel syndrome. Chronic fatigue syndrome. So that's not just being fatigued after lunch. That's someone who's fatigued pretty much day after day, all the time, frequently reporting feeling wired and tired. Migraines are common comorbidities, as are the conditions interstitial cystitis and TMJ disorders. Interstitial cystitis are individuals who have symptoms. You would think of them as urinary tract infections, but consistent urinary urinalyses are normal, and or treatment with antibiotics are not resolving the symptoms. TMJ disorders, temporomandibular joint, anxiety, depression, and as I mentioned, POTS, postural orthostatic tachycardia syndrome. Now getting into the triggers a little deeper, we're going to talk about emotional stress, hormonal changes, dietary changes, environmental changes, and that leads us into post-traumatic stress disorder and fibromyalgia. So going back to understanding this condition, again, in the 1990s, we'll say it this way, in the 1980s and 1990s, clearly there was a lot of debate surrounding the validity of fibromyalgia. Through time, researchers have been digging in, trying to understand why some people who appear healthy are in so much pain. And a lot of that research led to the finding that these individuals were under a lot of stress, that stress hormones, particularly hormones like adrenaline, seem to make the pain nerves more sensitive. A lot of you have this understanding that if you cut your hand, for example, you're going to experience pain. So there's a one-to-one relationship between cutting your hand and the pain that you feel. And that's where fibromyalgia is so confusing, because MRI scans are frequently normal. Blood tests are frequently pretty normal, yet there's so much pain that's being felt. So there seems to be an amplification of pain signals going on in the body of a fibromyalgia patient. It's also important to know that really until the signal goes from your hand to your brain, is actually in your brain, that's where it can be recognized as pain. But there's a number of relays between your hand and your spinal cord and your brainstem that are trying to filter out unwanted sensory stimuli like pain. Hence why I don't really feel the shirt on my back unless I think about it. And a fibromyalgia patient probably does feel the shirt on their back. So all that being said, as I alluded to, stress hormones seem to be a critical element of us understanding this concept referred to as central sensitization. And in understanding central sensitization, which is part of fibromyalgia, then that led researchers to look at the stress piece and examine, well, do fibromyalgia patients have a higher incidence of post-traumatic stress disorder? The answer we know is yes. And having heard hundreds of fibromyalgia patient histories, I can attest to the fact that I have heard many really devastating stories of trauma that fibromyalgia patients have gone through, frequently in childhood, of all the different types of trauma that a human can endure. And so what does that do to our brain is really the question. And we know when somebody goes through trauma at an early point in life, when the brain is not fully developed, and they may go through trauma later in life too as adults, which can be equally as bad. Relative to this discussion, though, it seems that the preponderance of fibromyalgia patients seem to have trauma earlier in life. Yes, they can have it later, but earlier in life is kind of where we're going to focus. So as the brain is developing, if you expose that brain to things that we don't think a child should probably be experiencing, what happens is that the fear center, known as the amygdala, gets bigger for all intents and purposes. It becomes hyperconnected, it overactivates. And when we have a part of your brain that's overactivating, and it's deep in the brain, deep in the medial portion of your temporal lobe, then what can happen is that it will signal, and that's what this diagram is showing you, through parts of the hypothalamus, pituitary, down to the adrenals, for the adrenal gland to release hormones like cortisol. Now, there's also a hardwired link that goes through the spinal cord down through the autonomic nervous system that will cause the center of the adrenal gland, which is neurological tissue, different than the endocrine tissue of the outer portion of the adrenal gland. And that center part of the adrenal gland will then start to release adrenaline, lots of adrenaline. And it's thought that that adrenaline then can be a critical factor as to why fibromyalgia patients experience so much pain. So this is a good article. I always try to give you some articles to go look at for those who are really interested. And this is a recent article looking at the association of post-traumatic stress disorder and fibromyalgia. Even a more shocking number than I've seen in the past, they're seeing that upwards of 84% of fibromyalgia patients in this study had post-traumatic stress disorder or some type of trauma before the diagnosis of fibromyalgia and before the pain came on. So that's really important. And a lot of you are going to ask me on YouTube. First of all, I can't really give you treatment recommendations through YouTube. And again, these are thoughts for all of you to talk about with your doctor. And I have people consult with me all the time on these issues in my clinic. But in essence, a lot of post-traumatic stress disorder components of fibromyalgia are frequently referred by doctors to psychotherapists, mental health professionals, psychiatrists. Many fibromyalgia patients have been through that treatment arm and may be looking for other avenues to pursue. But nonetheless, that is the standard right now as to how a lot of fibromyalgia patients are receiving treatment for their post-traumatic stress disorder. Now, autoimmunity and fibromyalgia. So this is where we dovetail into Hashimoto's. Hashimoto's refers to an immunological attack on the thyroid gland. I'll say it before you say it. I've had my thyroid tested and my thyroid is normal. I don't have a thyroid problem. My doctor has ruled out a thyroid problem. Certainly, many patients have had a thyroid hormonal problem ruled out. However, most patients that I see have not been tested for an immunological attack against their thyroid, referred to as Hashimoto's thyroiditis after Dr. Hashimoto Hakuro, who discovered the condition in 1904 in Japan. So Hashimoto's disease or Hashimoto's thyroiditis really designates when, just like with rheumatoid arthritis, and we can have an immunological attack on the joints of our hands or other joints of the body, this is designating we're having an immune attack on our thyroid. Many of you are aware of it. In the last 15 years, there's just been this explosion of awareness around Hashimoto's, but still some of you may not be aware of it. And it's very, very important to recognize this condition, even if your thyroid blood tests have been normal, even if your thyroid's still making thyroid hormone, because a lot of fibromyalgia patients have Hashimoto's. And there have even been studies where they examine a group of Hashimoto's patients. So these are individuals with this immune attack on their thyroid. And researchers commonly find that if you evaluate these individuals with Hashimoto's, they actually fulfill the criteria for having fibromyalgia because they have many associated symptoms of brain fog. One of the most common symptoms of Hashimoto's is brain fog. They can be fatigued and they can have pain throughout their entire body. So we're finding that Hashimoto's might be an underlying root cause for this clinical presentation of fibromyalgia. And as you'll see by the end of this, fibromyalgia, in my opinion, is not just one thing. We are so singularly focused in healthcare right now. It has to be one thing that causes one problem. And certainly there are conditions like that. There are many other conditions that are not like that. Fibromyalgia being one of them, where there might be 4 or 5 potential causes and an individual may have all 5. They may have 2 or 1. So that's how I look at this. Gluten sensitivity is another really significant issue in fibromyalgia patients. Varying importance depending on the study that you look at. One study that I've cited through the years on YouTube looked at a number of fibromyalgia patients. They did endoscopies on them and they found signs of inflammation relative to gluten, but not bad enough to be celiac disease. Celiac disease is an autoimmune, meaning immune system is attacking our body, an autoimmune illness to the small intestine largely. And it can cause many, many symptoms, but there might be variants or grades of severity of celiac disease. And that's where we get into this condition called non-celiac gluten sensitivity, which fibromyalgia probably falls into, where they looked, going back to this original study, they looked at this group of fibro patients, did endoscopy, saw signs of inflammation relative to gluten, but it wasn't that bad to be celiac. And they put them all on a gluten-free diet. And almost all of them, I think, had a significant improvement in their pain. They went back to work after 18 or 16 months. There are striking changes. So gluten can be a piece of the puzzle. Many of you may have tried going gluten-free, may have had great or suboptimal results. And again, that's where, when I'm trying to give you the overview of this condition, I hope that you can also envision that if you have 5 things wrong with your car and you fix one, the car may still not run correctly. Think of it that way. And that's where I see so many patients with chronic illness fall short because they may be doing something right, but not everything right. Small fiber peripheral neuropathy. So small fiber peripheral neuropathy, I started talking about this, I think, as soon as it came out. And I was really happy to read the initial study back then where it was noted that upwards of 40% at that time of fibromyalgia patients actually have damage to their pain nerves. So the nerves that sense and transmit pain and temperature were literally dying and degenerating in fibromyalgia patients. That's a really big finding because, again, go back to even 15 years ago, there was so much stigma around fibromyalgia. There still is, but I think it was even worse back then. And there was no validation for fibromyalgia patients. And the interesting facet of small fiber neuropathy is that it's just been confirmed in study after study, continent after continent, to where now it's an accepted root cause of the condition. So for those of you who may have had a nerve conduction velocity test with a neurologist, an EMG test with a neurologist, just know that those are tests for peripheral nerves that actually won't detect if there's damage to the small fiber nerves. Small fiber nerves are small in diameter. They don't have a lot of insulation around them, if any, and so they're not usually detected on our standard peripheral nerve diagnostic workup that neurologists do. You can see signs to indicate that there's involvement via neurological exam, which, according to my patients, don't seem to happen as thoroughly as they should because everybody seems to be rushed in our current healthcare model. But there are certain types of tests that can be done now to validate and further say if somebody has small fiber neuropathy. Some of those include the intraepidermal nerve fiber density test. Think of it as a skin punch biopsy, where then the piece of skin is sent to a lab. And at the lab, they evaluate how dense the small fiber nerves are in the skin tissue. Others are corneal confocal microscopy is really gaining a lot of traction. So that basically doesn't involve a biopsy. Typically that's done in an ophthalmology office where the ophthalmologist can see the density of small fiber nerves in the eyes. And small fiber neuropathy is not a condition like you would think with diabetic neuropathy, where there might be nerves that are dying and degenerating just in the feet or the hands. Small fiber neuropathy and fibromyalgia seems to affect all distant parts of the body, not in what we call a length-dependent distribution. So it's non-length dependent, meaning it's not stocking and glove like diabetics typically have. It can be throughout the entire body, including affecting areas like the eyes, and that's how we diagnose it. Other tests that are commonly done include the QSART test. I think it stands for Quantitative Pseudomotor Axonal Reflex Technique. That is not very common in clinical practice because I've seen it typically done at specialty centers here on the West Coast. I'm in Reno, Nevada, as well as seeing patients in Northern California. QSARTs that I know of are done at places like Stanford, UCSF. But there's, to my knowledge, I haven't seen anyone have a QSART test done in Reno, Nevada. And then we have mast cell activation syndrome. So I talk about mast cell activation syndrome a lot on my YouTube shorts. I think this is going to be kind of like the new fibromyalgia. It can cause an overlap with fibromyalgia. It can be a root for some of the fibromyalgia symptoms. In essence, what you need to know, think of most of your immune cells as being like Pac-Men. So a virus comes into your body, you have immune cells that are going to engulf the bacteria, the virus, and hopefully coordinate responses to get rid of those bacteria and viruses out of our body. Well, the mast cells, they actually vomit or degranulate certain types of chemicals that can be really critical for the healing response and are typically associated with allergic responses. So many of you know that antihistamines are frequently used for allergies. Well, histamine is secreted from mast cells, also basophils, but mast cells are this immune cell that are in our tissues. We're finding that a certain percentage of the population, there are two different criteria for this too, so hang with me, but we are finding that a fair amount of the population seems to have this tendency or proclivity for their mast cells to discharge too easily. And then when that happens, there's all of these inflammatory chemicals that can be associated with chronic pain. So mast cell activation syndrome now is part of my diagnostic workup when I'm looking at a fibromyalgia patient. And other associated symptoms of MCAS can include hives. So, and it's important to recognize that I'm not saying that MCAS is the sole cause of your fibromyalgia, but if you think back through your history, do you have a history of asthma? Do you have a history of seasonal allergies? Do you ever take Claritin or Xyzal or Allegra? Do you have a history of flushing? As I mentioned, the hives can be a big one. Do you sweat excessively? Do you have diarrhea? Do you have headaches? Do you have nausea and vomiting? Some of these are core symptoms of mast cell activation syndrome. And what we're finding is that what can be this tendency of the mast cells to oversecrete histamine and other inflammatory chemicals can then develop into other conditions like chronic pain. And so this is just a nice diagram depicting how mast cells can impact many different conditions. Here, this is a diagram relating to multiple sclerosis and other neurological conditions like Alzheimer's disease. And you can watch my other YouTube videos on that topic, including conditions such as chronic headaches and head pain. We find that histamine levels go up before migraines. How many of you knew that? I didn't know that until I read the study a couple years ago. So it's really, really interesting how mast cells are impacting our chronic pain. And here are some of the medical and functional models that are frequently used for addressing mast cell activation syndrome. And then there's Lyme disease. So Lyme disease is a really interesting condition. It's caused by the bacteria from certain types of ticks on the East Coast as well as the West Coast. The Centers for Disease Control, if I remember correctly, came out a number of years ago and said there are many more cases of Lyme disease than we originally thought. And I will say, working in alternative medicine, there are also alternative medicine practitioners who diagnose everyone with Lyme disease. So where's the middle ground? It's really difficult because we don't have a great test for Lyme disease at this point. And I say that with all the sincerity I have and lots of years of research on this condition. I think that's important to know. Medically, they've done studies where individuals have been bitten by ticks and they have a bullseye rash, and we know they have Lyme disease, but the tests lots of times will miss Lyme disease in 40% of those cases. So there's an inaccurate test for Lyme disease that's typically done in our standard diagnostic workup. So that's important to know. Also, it's important to know that the alternative tests, some of them can have false positive rates upwards of 40 to 50%. And I know frequently people are searching for answers, and my heart goes out to them. And I'm talking about this because I tend to have this question come up a lot. And the way I evaluate it, trying to be in the middle and trying to go with what I know, I try to look at an individual and say, okay, when did your problems develop? Did you live in a Lyme endemic area? Did you go camping? Did you ever have a flu-like illness that was untreated, even as a child? And then did you develop chronic symptoms right after that? And I think that's an important element of that history. That's why Lyme disease is so important to treat early on. If somebody is bitten by a tick and then they have basically 30 days to receive appropriate treatment, and preferably, if I remember correctly, within the first 7 to 14 days is ideal. And if they're not treated, then it can go into this chronic form of Lyme disease, which has a number of different names that draw anger from a number of different groups. But in essence, post-treatment Lyme disease syndrome is one, chronic Lyme disease is another. It is a real condition, so Lyme disease is very serious. I want to emphasize that, but I also want to emphasize that I don't think we can say that all fibromyalgia patients have Lyme disease, because I don't think that's accurate. Just like we can't say all fibromyalgia patients have small fiber neuropathy. A large percentage of them do, but not all of them. And so we need to consider like this Venn diagram model for fibromyalgia. And I'm pleased at this point because a lot of these things that I saw 10, 12 years ago have received so much validation. And I don't mean to say that in that way, but I mean, it's been an interesting journey to talk about small fiber neuropathy, going back 10 years ago, and now seeing it gain so much traction, so much validation in the literature, so that fibromyalgia patients can have answers now, because we can consider a certain subset of fibromyalgia patients, maybe upwards of half, as having a peripheral nerve condition causing their pain. And I presented these two articles going back to the Lyme disease model. One is done by on the right side of your screen, Arthritis and Rheumatology 2015. Basically, that study said that they looked at this group of fibromyalgia patients, and they basically wanted to assess culture-confirmed Lyme disease in these individuals, and they in essence found that 1%, if I remember correctly, in this culture-confirmed group of Lyme disease patients have fibromyalgia. So if you take all these people with Lyme disease and you really evaluate them, only 1% have fibromyalgia. So that was their case as to why fibromyalgia and Lyme disease do not overlap. Whereas the other side is a more recent study where they're saying that actually, if you see signs of an anti-nuclear antibody, it's a common blood test we doctors do for assessing, and everybody in healthcare for assessing signs of immunological dysfunction. It's like our first step into assessing for diseases like lupus. They saw these ANA positive fibromyalgia patients may have T cell responses specific to the Lyme bacteria, Borrelia. So, Burgdorferi, which I always kind of say quickly, Burgdorferi. I always miss that R piece to the Borrelia, Burgdorferi. But nonetheless, there is still some conflict as to what amount of fibromyalgia patients have Lyme disease, but that's my take on the condition. So how do we manage it? We manage it by doing a very thorough history. We manage it by doing a very thorough examination to try and see which of these pieces apply to the individual, what dietary changes may be able to be enacted, lifestyle changes, referrals to other specialists that may be helpful for the fibromyalgia sufferer. So you can go ahead and pause the video now. I do work with fibromyalgia patients from all over the planet, and United States, and locally here in Northern Nevada and Northern California. And yeah, I think it's a really interesting condition, and I hope that this has helped you. And if you have further questions about your case and you want me to evaluate that, you can see the information listed on the screen, 775-507-2000. So thank you for watching and have a wonderful day.
I'm Dr. Randall Gates, board-certified chiropractic neurologist and chiropractic physician. I've helped people from all over the world with chronic neurological disorders. If you would like for me to evaluate your case, go ahead and fill out the submission form below. One of my team members will reach out to you directly, and I look forward to talking with you.